Today my topic of presentation is approach to raised intracranial pressure. 4-year-old male patient on irregular antitubercular therapy presented at emergency with recurrent vomiting, headache, and altered sensorium, abnormal posturing. On examination, GCS was E2, M4, and V1. People was dilated and sluggishly reacting to light. Heart rate was 60 to 65 per minute. Respiratory rate 28 per minute, which was regular. BP was more than 98 centile, and saturation was normal. CBG normal. Eye restricted on eye examination. It was restricted upward gaze. On general examination, no pallor, cyanosis, jaundice. The patient got admitted at PICU, and there the MRI brain, it was found meningeal enhancement and ventricular dilation. So this is maybe a case of tubercular meningitis and presented as hydrocephalus. At the PICU, CSF manometry was done, and it was found to be raised ICT. This is the esophageal. This is the CSF manometry. ম্যাম শেষে একদম পুরোটা ছিল। হ্যাঁ না ম্যাম আরো বড় আছে, মানে এত বড় ভিডিও আসছিল না। Now introduction. Intracranial pressure is the total pressure exerted by the blood, brain, and CSF in the intracranial vault. Raised ICP is persistent elevation of the CSF pressure more than 20 millimeter of mercury for more than 10 minutes. According to Monro-Kelly doctrine, the sum of the intracranial volume of the blood, brain, and CSF is constant, and increase in any of these must be offset by equal decrease in another, or else ICP increases. This is the pictorial depiction of the Monro-Kelly doctrine. গ্রাফটা ম্যাম হ্যাঁ 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 ওটা আছে। The cerebral perfusion pressure is the difference between mean arterial pressure and the intracranial pressure. It is an important CPP. The cerebral perfusion pressure is the important clinical indicator of the cerebral blood flow, hence adequate oxygenation. Constant cerebral blood flow across a range of mean arterial pressure is attained through changes in the caliber of the cerebral blood vessel, which also known as autoregulation. When the mean arterial pressure falls below the lower limit of autoregulation, the fall in the cerebral blood flow results in ischemia or then infarction. Conversely, the mean arterial pressure when become too high, autoregulation fails, resulting in raised ICP. This is the graphical presentation. Below the 50 millimeter of mercury, there is cerebral blood flow resulting in ischemia, and more than 150, there is vasogenic edema. Causes of the raised intracranial pressure: it may be due to intracranial space occupying lesion, cerebral edema, or increased CSF volume. Normal values in the infants, it is 2 to 6 millimeter of mercury, and young children it is 3 to 7 millimeter of mercury, and in older children it ranges between 0 to 10 millimeter of mercury. Normal CSF pressure at the time of lumbar puncture is 12 to 28 centimeter of water. If the measured ICP more than 27 centimeter of water more than 5 minutes with sign symptoms is generally regarded as threshold for the treatment. Clinical feature, it may be different in case of infants and young children and older children. In case of infants, tense bulging fontanelle, irritable high-pitched cry, lethargy, distended scalp veins, feed refusal or vomiting, sunsetting, that means impaired upward gaze, increase OFC means increase in head circumference associated with split sutures. In case of children, the early manifestation is headache, vomiting, diplopia, pupillary changes like unilateral change in size or sluggish reaction to light, changes in the level of consciousness, and the late manifestation is Cushing triad, bradycardia, hypertension, and irregular respiration. Maybe projectile vomiting, decerebrate or decorticate posturing, unilateral, bilateral, fixed pupillary changes, and cardiac arrhythmia may also happen. Now the detection. Non-invasive detection of raised ICP. First we present as neuroimaging, CT scan of the head, MRI brain. CT scan of the head is a study of choice as MRI brain is time consuming. Midline shift, effacement of the basilar cistern, effacement of the salsa and thumb pinding of the gyral marking on inner table of the skull may be found radiologically. In CT scan of head is indicated in raised ICP like epidural hematoma, head trauma, obstructive hydrocephalus. It may also help to find underlying etiology like intracranial hemorrhages, space occupying lesions, and cerebral edema. Ocular ultrasound is the important modality. This is the ocular ultrasound in radiologically. In less than 1 year or open fontanelli, the cutoff is 5.2 millimeter, and more than 1 year, the nerve sheath diameter more than 5.8 millimeter is the cutoff. Fundus examination. In fundus examination, papilledema is seen. Papilledema, absence of papilledema doesn't rule out the presence of increased ICP. Grades of papilledema: grade 1, C-shaped halo with a temporal gap. Grade 2 papilledema, the halo becomes circumferential. Grade 3 papilledema, these are all ophthalmoscopic findings. Loss of major vessels as they leave the disc. Grade 4 papilledema, loss of major vessels on the disc, and grade 5 papilledema, get criteria of grade 4 and partial and total obscuration of all vessels in the disc. This is the false localizing sign, cranial due to irritation of the cranial nerve 6, and the features of cranial 6 nerve palsy presented as horizontal diplopia and lateral rectus palsy. This is a transcranial Doppler. It is based on approximate semi-quantitative relationship between the cerebrovascular dynamics and ICP. This is a tympanic membrane displacement. Non-invasive tympanic membrane waveforms were measured in the outer ear and used as input for estimation of the non-invasive ICP. Now coming to the invasive part, it is done by microinducer probe. The tip of the probe most commonly placed in the interparenchymal, but they can also be placed in the interventricular, subarachnoid space, subdural space, and epidural component also. This is the pictorial representation where the probe tip can be placed. Now coming to the raised intracranial pressure management portion. Neuroprotection is the main part. For this, the general measure will be assessment and management of the airway, breathing, circulation is the beginning point of the management. And intubation under the lignocaine, thiopental sodium, short-acting non-depolarizing muscle reactant like atracurium, vicurium for indicated for children less than GCS more than equal to 8, GCS less than 12, rapidly decline and evidence of herniation, apnea, loss of protective airway reflexes, refractory hypoxia, but the target EtCO2 should be around 30 to 35. Appropriate oxygenation, maintaining SpO2 more than 92% should be ensured, and in case of circulatory failure, fluid bolus should be given to attain state of normal with DNS in case of younger patients and normal saline in case of older children. After the initial assessment, the signs of herniation also be assessed because it is a life-threatening condition. On initial assessment, along with ABC measure, priority should be given to look for potentially life-threatening signs of herniation. As the Cushing's triad is the late sign of herniation, the various presentation of the herniation can be the in case of cingulate herniation, impaired consciousness, contralateral monoparesis of the lower extremities. Transcalvarial, it is the herniation of the brain through the surgical site or in any case of fracture, may be occurred during craniotomy surgery also. The upward cerebellar and the central, uncal and tonsillar herniation may also be present. In case of tonsillar herniation, impaired consciousness, neck rigidity, decerebrate rigidity, irregular respiration, bradycardia can be present. Positioning, as the during raised intracranial pressure, all the blood is drained through the jugular venous system. The head should be positioned in the midline with the head end of the bed elevated to 30 degrees to encourage jugular venous drainage. In case of shock and once herniation occurred, head should be kept flat to promote cerebral perfusion. Then the head and elevation should be detrimental. Pain and sedation. Short-acting analgesics, sedatives, and muscle relaxant should be used to blunt the response to noxious stimuli. Lignocaine should be used prior to suctioning. Nebulization with 4% lignocaine mixed in 0.9% saline or IV as 1 to 2 milligram per kg as 1% solution given prior to suctioning. This is the graphical representation of ICP and cerebral perfusion pressure and mean arterial pressure at various degree of elevation. And this is the range of the graphical representation of the various like turning, suctioning, and during budding, the raised ICP, how the raised ICP is measured. This is the graphical representation. Temperature control, as the hyperpyrexia increases cerebral metabolism that leads to increase in cerebral blood flow. Child with raised ICP should be prevented from the becoming febrile with antipyretics, anticonvulsant drugs. The active seizure should be managed with lorazepam, midazolam, and the prophylactic anti-seizure drugs should be added to those who are at risk of seizures like parenchymal injury, traumatic brain injury, and depressed skull fracture. Blood glucose levels should be, normoglycemia should be targeted between 80 to 120, but it can be maintained up to concentration of 180 milligram per dl. If the glucose level is greater than 200 milligram per dl on 2 consecutive measures, insulin should be used. And the blood pressure, in case of untreated large intracranial mass, lowering of a BP may be detrimental as cerebral perfusion pressure is maintained by high mean arterial pressure. SBP should be maintained more than 5th centile for the age. Otherwise, the short-acting beta blockers, center alpha receptor agonists are preferred agent. Anemia, the hemoglobin level should be maintained above 7 milligram per day. Fluid therapy, main goal of the fluid therapy to maintain euvolemia, normoglycemia, and prevention of hyponatremia. Only isotonic or hypertonic fluids like linger lactate, 0.9% saline, 5% dextrose, 0.9% normal saline should be used. Central venous pressure should be maintained between 7 to 11 millimeter of mercury, and the serum sodium should be maintained between 145 to 155 milliequivalent per liter unless using hypertonic saline. And the serum osmolarity should be maintained below 320 milliosmol per kg. Now, after the general measures, first tier measures, osmotherapy, hypertonic saline should be used. In case of osmotherapy, 20% mannitol at the rate of initial bolus of 5 ml per kg of 20% solution given as rapid infusion over 15 to 20 minutes, then 1 to 2 ml per kg every 4 hourly as per requirement up to 48 to 72 hours. But hypertonic saline is the preferred in case of hypotension, hypovolemia, serum osmolarity more than 320 milliosmol per kg, and in case of renal failure. Target sodium should be 155 to 160 milligram per liter. Steroids indicated in case of intracranial tumors with perilesional edema like neurocystic sarcosis, edema, pyomeningitis, abscess, tubercular brain meningitis. Acetazolamide in case of hydrocephalus, idiopathic intracranial hypertension, high altitude, and increased sedation and associated with paralysis should be maintained, as any kind of stress increases the pressure inside the brain. And finally, the CSF diversion procedure like ventricular peritoneal shunt, external ventricular drainage, these all are used as immediate measure to reduce the intracranial pressure. Second tier measures, decompressive craniotomy, it can be done in combination with evacuation procedure or as a primary treatment. These all are indicated in focal space occupying brain lesion like example brain tumor, cerebral abscess, diffuse swelling on NCCT, injury less than 48 hours old, no sustained episode of elevated ICP before surgery, GCS is more than 3 on at least one prior assessment, evidence of evolving cerebral herniation syndrome. And in case of impending cerebral herniation syndrome, hyperventilation should be done with PaCO2 35 to 38 millimeter of mercury, in whom surgical intervention is planned. Aggressive hyperventilation with PaCO2 between 28 to 34 millimeter of mercury indicated in those if there is any clinical signs of acute herniation. And the barbiturate coma, barbiturate decreases the cerebral metabolic rate, thus the increases the cerebral blood flow. Phenobarbital and thiopentone should be used for this purpose. The main purpose of the barbiturate coma is to achieve the burst suppression at the interval of 5 to 15 second suppression. Hypothermia, this is not the recommended, but according to recent guideline, late application of the moderate hypothermia during the second tier management is an option. Initial reduction to 35 plus minus 1 and then 33 plus minus 1 degree centigrade is recommended. This is the flowchart of how the cerebral perfusion pressure maintained during ICP. And again, the CSF manometry, which was done for this case. Thank you.
So initial part was okay, but later part was too common. Okay, but I cut the slide में आस्ते आस्ते बोली. We policies nobody has studied, huh? Which is good. 8 slides below are okay. The last few slides, management portion, শুনিয়ে হয়েছে rather flowchart দিয়ে একটু হালকা ভাবে বোঝালে সেটা বোঝা যাবে নিশ্চয়ই. কর শুরু থেকে কর. Yes, this is good. Now, acne. Let's just like the recurrent vomiting, headache, altered sensorium, posturing. That's it. Pupil is dilated, sluggishly reactive. So, what is the early pupil brainstem herniation? What is the contraindication for it? LP contraindication key. Raised intracranial pressure or with impending herniation?
Raised intracranial pressure with impending herniation. And second is platelet less than 50,000.
50,000. More than 90,000.
Unstable.
Local.
Local pathologies.
So these are the contraindications. Otherwise, we can do. Very. Now, if there is sluggishly reacting pupil and dilated, what does that mean? Brainstem herniation has proceeded or it's just started? It's proceeded. Initially, there will be anisocoria, inequality of pupils on sides. Later, it will become sluggishly reacting and then mid pupil. কিছুতেই রিঅ্যাক্ট হচ্ছে না, আর ফেলিয়ার হচ্ছে না, আর না। তারপরে রেসপিরেটরি রেট বলেছিস, রেসপিরেটরি প্যাটার্ন কি হয়?
ইউজুয়ালি ইরেগুলারই হয়,
চেঞ্জ তো রাইট। বিপি ইজ ওকে, হাইপারটেনশন, ব্র্যাডিকার্ডিয়া, তাই তো?
মানে পুশিং ট্রায়ালটা।
তাছাড়া
সানসেটিং ব্যাপারটা, সানসেটিং
সেটা বেশিরভাগ বিজ্ঞানী হাইপোক্যাথালামাস চিলড্রেন, তাই তো? বাই হোয়াট ইজ দিস? কেউ জানে? পেরিনয়েড সিনড্রোম, and there is upward gaze is restricted, so the child will put it down. Okay, তারপরে এটা তো ঠিক আছে, হাইড্রোকেফালাস এটাও ঠিক আছে। Now over here for the normal CSF pressure তো বলেছি up to 20,
মানে 20, মানে যেটা এখানে যেটা দিয়েছি আমি, যে হ্যাঁ মানে নরমাল সিএসএফ এর এটা লাম্বার পাংচার ডিউরিং 12 to 28 সেন্টিমিটার অফ ওয়াটার, বাট মোর দ্যান 27
millimeter of mercury, right? So 27 centimeter of
water
20 millimeter of mercury. আমরা ওখানে mercury দিয়ে measure, practically we measure with mercury, right? Then what is mean arterial pressure?
It is the difference between
Now, the
systolic
cerebral perfusion pressure. Actually, we need to see the cerebral perfusion pressure. So earlier it was told 30% prediction restriction of the fluid. Now it's told not to reduce the fluid because then there will be hypoxia. Fluid कम के लिए cerebral perfusion कम होगा. That is more dangerous. Okay. Cerebral perfusion pressure होच्छे mean arterial pressure
minus ICP. हाँ.
Mean arterial pressure. 1/3 of.
Oh, 1/3 of diastolic BP.
1/3 of the
BP. हाँ, minus 1/3 pass
होते पारे आरेकटा rough होच्छे 1/3 of the बोधहय age of weight of the child. এটা একটু দেখে নিস প্লাস 55 না কি একটা ছিল একটা বলে দেব একটা ফর্মুলা আছে in arterial pressure. Okay. তারপর একটা দিন these are the clinical features. When will the OFC be increase
head circumference
when there is the fontanelle is open. So fontanelle open থাকলে till ওই compensatory partটা we can rest assured. So that doesn't mean your herniation হবে না তারপরে if the crisis then there is brain stem. Okay. So in infants actually these signs are very difficult to get symptoms headache vomiting convulsion. So this infant will be just irritable and they'll be a cry. Okay. And lethargy, extended scalping, these are all okay. Then after that, so pupillary changes I told, anisocoria followed by the mid-fixed pupil. Okay. Then vision difficulty. What is the vision difficulty? Does anybody know? What is the vision? একটু বড় বাচ্চা বলতে দেখতে
diplopia
visionটা যায় peripheral প্রথমে যায় তারপরে central. Okay. And when you are telling this diplopia is that is okay. Changing level of consciousness, sluggish reactions, pushing stride. What is decorticate and what is cerebral posturing? That is an end part. What is it? Decorticate me or cerebral? Decorticate you don't have. Decorticate শুয়ে রয়েছে পাগুলো angle flexion, knee extension এরকম করে রয়েছে. Decerebrated, this is like this. Okay. So that is total cerebrum is gone. It is more lethal. That's it. তারপরে যখন বলবি you analyze everything then you will practically তোর মনে রাখবে. Okay. Neuroimaging CT scan and MRI are almost equal. That's okay. কিন্তু একটা জিনিস MRI করে যে CT scan করে সেটা হচ্ছে তোর কি টাইপ অফ edema. Okay. Cerebral edema কি ধরনের হয়?
একটা তো সাইটোটক্সিক হয় একটা ভ্যাসোজেনিক হয় ইন্টারস্টিশিয়াল হয়
সাইটোটক্সিকটা কিসের হয় বল
সাইটোটক্সিস মানে কোনো পয়জনিং ট্রমাটিক যখন অ্যাকশনাল কোনো একটা ডিসরাপশন হচ্ছে তখন সেটা সাইটোটক্সিক
হেড ইনজুরি এজন্য চাইল্ড অ্যাবিউজও কিন্তু মনে রাখ আর এইচআই কমনলি যেটা আমরা পাই ভেসোজেনিক
মানে যখন ব্লাড ব্রেন ব্যারিয়ার ইজ ইমপেয়ার্ড মেনিনজাইটিস হতে পারে
মেনিনজাইটিস যে কোনো সিএনএস ইনফেকশন সেখানে কিন্তু নিউরনাল ইনসুলিন তো হয় তাহলে আমরা কিছুটা আরএসিপি কমালে এটা আবার রিভাইভ যায় ইন্টারস্টিশিয়ালের एग्जांपल সিএসএফ বেশি এরকম হাইড্রোকেফালাইটিস এই তিনটে মাথায় নিয়ে রাখতে হবে আমরা ইউজুয়ালি ভেসোজেনিক হেড ইনজুরি দেখি না ইনজুরি দেখতে সাইটোটক্সিক ওকে তারপরে তাহলে এমআরআই ব্রেন আমাদের কিছু ডিফিউশন রেটেড কেস আছে আমি অতটা জানি না এমআরআই DW2 রেটেড ইমেজ আর বোধহয় DWI ডিফিউশন রেটেড ইমেজ এগুলো দিয়ে কোথায় কোন ইডমাটা বোঝাবে ওকে অন্য তোমাকে মিস করছি আমি টিপি হিসেবে সেবা এবার পিআই স্পেশালিস্ট তারপরে বল তারা বলে নি এটা ঠিক আছে অপটিক নার্ভ শিট ডায়ামিটার ঠিক আছে বাট এটা বাচ্চাদের ইউজুয়ালি করা যায় না প্র্যাকটিক্যালি স্পিকিং আর বাচ্চাদের করে দেখাটা একটু ডিফিকাল্ট বাচ্চারা নড়ে করা যায় না আমি জানি না এটা কতটা স্ট্যান্ডার্ডাইজ 5.2 টা কোনো স্ট্যান্ডার্ড বইতে আছে
হ্যাঁ এমসপিকো প্রোটোকল
rates of papilledema endoscopy important early তোমাকে পিক আপ করতে হবে চারটি গ্রেড বলেছে বাট উই হ্যাভ টু পিক আপ early ঠিক আছে তারপরে false localizing sign